Jen, from your point of view, where do you think things really broke down?
I think there are probably many points along the way at which there was rupture. And I think there are many points along the way my mother's a professor of nursing, picked up and continued. So I can't really pinpoint one exactly. I'm actually very thankful to hear that it's becoming recognized that PTSD very commonly travels with physical injury, often presenting with chronic pain, because it only makes sense. You get blown up, you've experienced trauma. It stays with you mentally. We had a lot of experiences where Peter was not eligible or turned away for treatment for a physical issue because of a mental issue, or he was not eligible or turned away for mental treatment because he had chronic pain and had been prescribed huge amounts of medications. So I think that's one point that I really appreciate, and I think that was a breakdown. I think another breakdown is that he didn't have unified care, and that's actually what we were seeking after he had been out-processed from the military and gone to the VA. We were looking for one place that could treat him sort of holistically for orthopedic problems, psychiatric problems, and pain management, including medication problems. It was a common refrain. We felt he was over-medicated. No one person who has PTSD as severely as he does with short-term memory loss is going to be able to medicate themselves with 15 different medications. I mean, I'm a lawyer. I had to build a schedule and give him the pill. So when you take a patient like that and you send him home or you put him in his room on base, you provide him with very limited access to mental care and no access to physical rehabilitative care, it's not going to go well. And at the VA, I think that there were some very strong attempts to bring in unified care, but unfortunately, at the end, he was prescribed medications, and those medications led to his death.
Right. So, what happened was because Pete was dealing with his pain issues, he ended up getting treated with morphine and ended up just sort of going to sleep one night and did not wake up. So it took a few months for the coroner to figure out what happened, and it turned out that it was an accidental morphine overdose.
Well, and it's really surprising for us because as the family, we didn't know that Peter was on morphine. Peter had gone to the VA seeking help. Peter recognized that he'd been on these medications for a long time. He felt he had a dependency issue, and he went inpatient in the VA to be backed off of these medications. And then he went to the multidisciplinary pain clinic, where a resident actually decided to reinitiate morphine in conjunction with codeine while he was on Valium. He was an opiate-naive patient. He had been off for a number of months. He had lost weight, and the result was unfortunate, and we lost him.
So I know, Dr. Webb, that you weren't necessarily involved with the care at the end there, but as a clinician, I guess, how can we make sure that we balance these things? I mean, he had the pain, so he needed something to treat it, but he also, had this whole sort of multitude of other problems. I mean, what are you supposed to do in a situation like that?
Again, to speak more in generalities instead of the specific case, because I don't know the details. I didn't prescribe medication for him. But in general, of course, it is very difficult, and safety, of course, is paramount in prescribing any medication. For pain, there are a variety of approaches that should be tried before opioids. Non-steroidal anti-inflammatory agents, muscle relaxants, Neurontin. There's various medications that would be tried first. With opioids as a last resort, they call that the ladder approach as you work up. And the use of opioids in chronic pain has gone through a metamorphosis during my career, from not being advocated initially as being too dangerous to being overused, and then people felt they shouldn't be used for chronic pain unless there was malignancy. But more recently, there's been a feeling among medical people that pain is undertreated. And in fact, in California now requires physicians to keep their licensure up to take 12 hours of pain management training. Because the feeling has been that in the past, physicians have been reluctant to prescribe medications to relieve pain, that some physicians won't prescribe them at all because they are worried about possibly a bad outcome. And so one has to balance, it gets down to clinical judgment, is when is it safe to give opioids? Some of the things we do, we ask patients to sign an opioid agreement before they would take them. which gives sort of guidelines for their safe use, not to drink alcohol, not to take doses not prescribed, not to seek from additional providers, not to come back with a story your dog ate them, things like that. But of course, people can sign that, and they may be sincere at the time, but obviously if they have other mental issues, things troubling them, and in the heat of a severe pain, they may decide to take extra pills. That's always a risk. And,
Or they may forget.
Or they may forget they took it.
Yeah.
And again, I'm not talking about Peter. I'm just talking about in general.
In general.
People may drink when they're not supposed to. There are various things that can happen. Impulsive behavior when you have PTSD or traumatic brain injury. So there is a danger, but yet can we not treat? It's been said there's a moral imperative to treat pain. And someone who has PTSD, who's in pain all the time, can't really deal with their PTSD because they're so miserable from their pain. So it's like any medicine. It's a two-edged sword. Opioids can be very effective in treating chronic pain, and they can also lead to a bad outcome. And I guess it comes down to clinical judgment and careful follow-up and prescribing them.